Hello, my name is Tom Mollsen. I'm a fellowship-trained manual physical therapist. I'm presenting to you today from a clinic in Des Plaines, Illinois. Des Plaines is a suburb about 15 to 20 minutes northwest of the city of Chicago in the United States. Dear Professor Shakil Ur-Rehman, Rifa University faculty members, professors, colleagues, ladies and gentlemen, it is an honor and a privilege to be your keynote speaker and to be able to address the past and future of rehabilitation sciences. Furthermore, I am honored to be here on behalf of the Ola Grimsby Institute. As an introduction, the Ola Grimsby Institute is a world-class consortium of physical therapists and physicians. It has a 45-year-plus history providing continuing education for physical therapists, manual therapists, and practitioners in the United States, Europe, South America, and Asia. The Ola Grimsby Institute consists of a team of instructors taught by and brought together by the Institute's founder, Dr. Ola Grimsby. As you can see, there are a wide variety of instructors, many of whom have been with the Ola Grimsby Institute since its inception. The programs offered by the Ola Grimsby Institute are the result of a lifelong dream of Dr. Ola Grimsby's to create an academic and clinical residency curriculum for physical therapists throughout the world. This weekend, we will be hearing from a number of eminent and leading academic scientists, researchers, and scholars on all aspects of rehabilitation science. As we look forward to what's going to be in store for us the next 2 to 3 days, I'd like to take my time today to focus on a paper I wrote recently updated relating to spinal manipulation. I originally wrote this paper in 2015. I thought a great way to prime us for the information I will be presenting today from this paper would be to start with a brief history of spinal manipulation. In particular, I'd like to focus on the theories which have been developed, attempting to explain the effects of spinal manipulation and examine how these theories have kind of progressed over the years. This slide shows a statue at an ancient Buddhist temple. The statue is said to be over 2,000 years old, showing manipulation of either the lumbar spine or the sacroiliac joint. In recorded history, manipulation can be traced back to the days of Hippocrates, who is often referred to as the father of medicine. This figure is from Hippocrates' book, Corpus Hippocratium. It illustrates the use of lumbar distraction with manual mobilization for the treatment of a person suffering from the lumbar kyphosis. This figure, also from the Corpus Hippocratium, illustrates another method used for the treatment of lumbar kyphosis. In this instance, we have the patient their spine is being distracted by a number of ropes and pulleys, while at the same time the clinician walks along their spine. After Hippocrates, a noted Roman surgeon, Claudius Galenos, also advanced the use of spinal manipulation, building on Hippocrates' work. In 18 of his 97 surviving treatises, Galen commented on the works of Hippocrates with many illustrations of his manipulative techniques, which are even today in medical textbooks. Galen wrote about curing a man with numbness in the 3rd, 4th, and 5th fingers of his hand by addressing the individual's cervical spine, where he felt there was an injured nerve causing the problem. Abu Ali Ibn Sina, or Ibn Sina, was an Iranian physician-philosopher who was born in the 10th century. He became famous for his work while he was the director or head of a large major hospital in Baghdad. He wrote the Keynote, the Canon of Medicine. This book contained most of the medical knowledge known at that time. It was used as the standard medical textbook not only in the Islamic world, but also in Europe up until the 18th century. When it was translated into Latin in 1595, it showed illustrations of Hippocrates' methods of treating a back. Another physician, Abu al-Qasim, who was Spanish-Arabian, wrote the Ars Medicina. This textbook of surgery also had illustrations of spinal manipulative or distractive techniques. During the Renaissance era, a French physician and surgeon by the name of Ambreos pare used armor similar to what we see on the figures or the torsos of the figures in these drawings to treat the spine of patients suffering from tuberculosis. He also used manipulation and traction techniques similar to those used by Hippocrates. During the 1600s to late 1800s, the bone setters flourished throughout Europe. Practicing bone setting required no formal medical education, as techniques were often handed down from one family member to the next, generation after generation. The name bone setting was used because basically these practitioners felt that what they were doing was replacing bones that were out of place. The first bone setter with a well-recorded history was the individual identified in this figure. Her name was Sarah Mapp. She was trained in bone setting by her father, who was also a bone setter. She treated the niece of a famous physician who had a large practice among the nobility at that time. Sarah Mapp, like many other bone setters, had no formal medical training or education, yet she, like the others, had considerable skill and could often cure cases where physicians had failed. Although bone setters were often maligned and scoffed at by physicians in Britain during the 1800s, they continued to build outstanding reputations as clinicians, treating patients including royalty, nobility, famous actors, members of the parliament, and even outstanding athletes. Wharton Hood was a trained physician. He described manipulation techniques in the Lancet Journal in 1871. He also published the book titled On Bone Setting. It was the first book of its kind by an orthodox medical practitioner. He believed the sounds that you heard when you manipulated a joint were the result of breaking up adhesions at that joint. Among the ranks of bone setters came several famous orthopedic surgeons, including Hugh Owen Thomas, who was actually the father of British orthopedic surgery. It would not be until the 1900s that the British Orthopedic Association would formally recognize the value and skill of these practitioners. Now, in 1874, Andrew Still founded osteopathy. With the first school formed in 1892, Still believed that the body had an innate ability to heal itself. He felt that by using spinal manipulation, one could correct any structural malalignment, allowing blood to flow more easily through the entire body. He felt that this would restore the body to a state of homeostasis and ensure natural healing ability. Chiropractic was founded in 1895 by Daniel David Palmer, also known as D.D. Palmer. The first school was formed in 1897. Palmer's son, Bartlett Joshua, or B.J. Palmer, later ran the school. B.J. was a terrific marketer and really promoted the growth of the chiropractic profession. The original chiropractic philosophy stated the adjustment of subluxed vertebrae removed impingement on the nerve and restores innervation and promotes healing of disease processes. Like the bone setters, by the 19th century, a significant portion of established medical professionals condemned the osteopaths and the chiropractors. Oftentimes, the success of these practitioners was attributed to luck more than any skill or knowledge. Alan Stoddard isn't listed among the names here, but I want to mention him because he was a medical and osteopathic physician who used skillful and specific manipulation techniques. He authored 2 textbooks on osteopathy, and like the others mentioned earlier, he influenced many physical therapists. Freddie Kaltenborn, he was a physical therapist originally from Norway. He developed the Nordic approach to manual therapy and related manipulation to arthrokinematics, or the movement of joints. He developed an extensive long-term training program for physical therapists first in Norway and later throughout Europe, North America, and Asia. Geoffrey Maitland was an Australian physical therapist who was influenced by Cyriax and Stoddard. He developed the 1 through 4 grading system for oscillatory manipulative techniques. In his writings, British surgeon James Cyriax refers to the competence of the Norwegian manipulators as well as their educational program. If you look in this slide, we have a picture taken at the first manual therapy exam in Norway in 1954. If you just look to our left of center, you can see Dr. Cyriax underneath his name. Next to him on his right is Freddie Keltenborn, and then to the right of Freddie Keltenborn was another famous physical therapist from Norway, Oddvar Holten, who developed medical exercise therapy. Like Dr. Manel, Dr. Cyriax was a major proponent of the practice of manipulation by physical therapists. After World War II, a group of Norwegian physical therapists developed a body of manipulative skills based on the diagnostic methods developed by Dr. Cyriax and the osteopathic techniques developed and taught by Dr. Alan Stoddard. Numerous schools of thought developed in the years following 1960, with graduates of these programs teaching courses all over the world, developing a rich variety of clinical approaches that were made available to physical therapists. Nowadays, it seems as if every physical therapy program out there offers some form of postgraduate work in some specialized area of physical therapy, including the area of manual therapy. Some even offer online courses. So in looking back at the practitioners who have had made major contributions to the area of spinal manipulation over the years or throughout history, Dr. Stanley Paris, himself a noted physical therapist and educator, found he could classify these early practitioners according to their views relative to the mechanism underpinning the effect of spinal manipulation. He identified these as so. Replacing material was a theory kind of used by Hippocrates, chiropractors, and Dr. Cyriax. Centralizing pain was the purview of Jeffrey Maitland. Normalizing arthrokinematics fell to the area of the osteopaths, the Manels, Alan Stoddard, and Freddie Kaltenborn. I would argue that the bone setters could probably be placed under the replacing material category. Now, in review, spinal manipulation has been used for over 2,000 years. During this time, numerous hypotheses have been formulated or offered to explain the mechanism by which spinal manipulation has its effect. Some of these theories were widely criticized, while others, including the biomechanical and neurophysiologic models, continued to gain evidence and support. Classic forms of manipulation were based on biomechanical philosophies of the bone setters or bone setting, malalignment, and hypomobility. But as time has gone on, theories have moved in a new direction with the integration of central neurophysiological influences on joint systems based on the work of the likes of Dr. Irwin Corr and Dr. Barry Weick. Between 1975 and 2009, a number of studies began to support the idea that the mechanical stimulation which occurs as secondary to spinal manipulation produced a barrage of afferent input into the dorsal horn of the spinal cord. This in turn initiated a cascade of neural responses, including complex interactions between the central nervous system and the peripheral nervous system, resulting in the desired effect. Now, of interest, 3 studies between 2002 and 2009 proposed the effects of spinal manipulation were perhaps due to neurophysiologic mechanisms mediated not only at the peripheral and spinal levels, but might also involve supraspinal levels. This was especially true as it relates to pain modulation. These studies are noted in the reference section at the end of this presentation, and I'll indicate them now. Picker, 2002, Schmidt et al. In 2008, and Bielaski et al. In 2009. I feel it's important to note that these 3 studies recommended future research aimed to identify those areas of the brain or central nervous system pathways that might be involved in mediating these effects. Healthcare practitioners worldwide utilize spinal manipulation to treat a number of physical impairments. 2 of these impairments include increased paraspinal and extremity muscle tone, as well as paraspinal and extremity muscle weakness. Numerous randomized controlled trials and systematic reviews exist supporting the efficacy of spinal manipulation in the treatment of patients. Now, one of the first topics I looked at in my paper was the use of spinal manipulation for inhibition of increased paraspinal and extremity muscle tension. I found that between the years 1979 and 2019, there were 15 randomized controlled trials and 2 systematic reviews which identified the presence of a reflex response in muscle evoked during the spinal manipulation, which may have caused a reduction in muscle hypertonicity in muscle groups both local to and distant from the manipulated joint, including the paraspinal muscles as well as the hamstring muscle group respectively. 2 studies found that there was a 25% reduction in muscle tone in these regions following manipulation. 3 studies examined the influence of spinal manipulation on the Hoffman reflex or H reflex. Now this H reflex, this is a measurement tool which can be used to examine neurologic function. More specifically, it's an estimate of alpha motor neuron excitability. It is used to assess spinal reflex pathways that project onto a target muscle. These studies found the application of the spinal manipulation technique at the lumbar level resulted in a reduction in the Hoffman reflex. This indicates that spinal manipulation may decrease alpha motor neuron excitability at muscles in the corresponding lower extremity, which is segmental in origin. So, knowing that we can use manipulation to decrease muscle hypertonicity, let's examine how we could use this in a clinical setting. So, consider a patient entering the clinic with complaints of parascapular muscle pain and limited shoulder range of motion bilaterally. Objective findings at the time of the initial evaluation include the identification of a forward head posture and the associated thoracic kyphosis. Palpation reveals increased muscle tone and tenderness at the paracervical, paraspinal, and parascapular muscle regions bilaterally. Functionally, the patient, examination of accessory joint motion indicates the patient is hypomobile at the thoracic vertebrae. Functionally, the patient demonstrates scapulohumeral dyskinesia with active movements of the shoulders. Now, in this clinical scenario, a manipulative technique directed at the thoracic vertebral segments, in addition to restoring normal physiologic motion to the involved segment, will afford a reduction in local muscle tension. Such an outcome may allow the physical therapist to begin to address motion at the hypomobile thoracic segments through mobilization exercises, as well as to vascularize the guarded paraspinal muscles with properly dosed therapeutic exercises. In addition, the inhibition of muscle guarding at parascapular and the shoulder muscles may improve myokinematics at the scapulohumeral complex, both actively and passively. The second topic I looked at was spinal manipulation for the activation of muscle and increase force output. So between the years 1999 and 2021, I found that there were again 15 randomized controlled trials and 2 systematic reviews, which found spinal manipulation resulted in an increase in muscle facilitation or activation of muscle, and an increase in muscle strength. Some studies suggested local and distant muscle strength gains were due to changes which occurred in peripheral pathways, while more recent studies has findings which suggested changes in central pathways with alterations in central cortical control. These more recent studies examine the effect of spinal manipulation on the H reflex, maximal voluntary contractile force, and V waves. Now, a V wave is a measure of supraspinal input or cortical drive to a motor neuron pool. So if you have an increase in V wave size, it indicates either an increase in motor neuron discharge rates or an increase in motor neuron recruitment, which may reflect an increase in supraspinal input into the motor neuron pool. These studies found that upon looking over their results, there was little to no change in the H reflex parameters, while maximal voluntary contractile force and V-wave changes increased following spinal manipulation. These findings suggest spinal manipulation alters motor preparation and commands from the supraspinal regions. So again, knowing this, let's go back and look at an example in the clinical setting. So consider a patient entering your clinic with subjective complaints of anterior knee pain and same-side lower extremity weakness. While taking the patient's history, you find the patient is 10 to 12 months status post an ACL reconstruction using a patellar tendon autograft. Furthermore, the patient had formal physical therapy following surgery and was discharged successfully. Objective findings at the initial evaluation include decreased activation and strength of the ipsilateral quadriceps muscle group, tenderness at the ipsilateral patellar tendon, as well as a facilitated L3 spinal segment. So in this clinical scenario, one could assume the facilitated spinal segment may have occurred as a result of an increase in abnormal afferent input at that spinal segment, secondary to either the initial musculoskeletal trauma causing the tear of the original anterior cruciate ligament, perhaps due to trauma caused by the surgical procedure, or perhaps due to the prolonged post-surgical pain at the involved knee for the past 10 to 12 months. Perhaps it's a combination of all three. A facilitated segment at the L3, a facilitated or sensitized segment at the L3 spinal segment can increase pain sensitivity and alter normal motor patterns at the involved knee. A spinal manipulative technique directed at the L3 segment could be utilized to improve supraspinal input into the motor neuron pool, resulting in improved muscle activation patterns at the involved quadriceps muscle group, as well as an increase in knee extension force. This would also improve coordination and motor performance at the involved tibiofemoral joint and patellofemoral articulation. Addressing the segmental sensitization prior to performing any training or direct training to the knee may improve motor performance, allowing for a higher level of training during the exercise component of the treatment session. So, some recent studies have suggested that there has been a paradigm shift in our thinking relative to the involvement of cortical structures following a spinal manipulation. To elaborate, when I originally wrote my paper in early 2015, the studies I examined proposed the effects of spinal manipulation on muscle tone and muscle facilitation or strength were due to a mechanical stimuli provoked by the manipulative procedure, which initiated a cascade of neurophysiological changes at the spinal and peripheral levels. As indicated, some studies hypothesize cortical structures might be involved. The last few months, as I updated the paper for use in the Ola Grimsby Institute curriculum, I found newer, more recent research, especially over the last 3 to 4 years, obtained findings which seem to indicate neurochemical changes take place, which are mediated not only at the spinal and peripheral levels, but also at the supraspinal level, supporting what earlier researchers have hypothesized. 3 of these studies suggested there's a possibility of a combined effect involving biochemical, neuromuscular, and neurophysiological pathways that need to be considered. The question I ask is there a paradigm shift in our thinking, or is this just the progression of our thinking, as we now have technology sensitive enough to confirm what has been hypothesized, discussed, and written about for a number of years now? Some final thoughts. The effect of spinal manipulation on the motor system continues to be inconclusive, as some studies support inhibition of the motor system, while others indicate facilitation of the same system following spinal manipulation. How does the autonomic nervous system know if a muscle needs to be inhibited or facilitated? And at what level or levels of the autonomic nervous system does this decision take place? Is it just a matter of bringing things to a state of homeostasis, as Andrew Still suggested so many years ago? I think it would be interesting to see a study where a patient has a weak muscle in one area or one muscle group, while on the other side there is some hypertonicity in a muscle group. And what occurs there following a manipulation at the spine? Be interesting to see. It is clear more research is needed to better understand the neuromuscular influence of spinal manipulation, as little is known regarding those neural adaptations involved in muscle inhibition or facilitation following the technique. As with other healthcare disciplines, physical therapy and more specifically manual therapy have limited research from sound, randomized controlled trials to support the efficacy of their treatment modalities, including manipulation techniques. Although the application of segmental manipulation can demonstrate positive results clinically, research findings are inconsistent and contradictory. Until a complete physiological explanation for the positive clinical results is fully understood and explained through the use of sound experimental trials that can be reproduced, the use of spinal manipulation as a viable method of treatment will always be questioned. We need to know what changes occur when we place our hands on our patients and perform a manipulative technique. Here I have listed the references, as I mentioned earlier. These references now are not only just for the presentation today, but I did use them directly from my paper. Okay, so if you're interested. Thank you so much for listening and for your attention. I sincerely appreciate the opportunity to speak with you all. Please enjoy this weekend's activities. Thank you.